So the next lovely video side. Next speaker is our own Dr. Minu Mathen. Tips to master using Bhex ring. The time allotted is 8 minutes, so I would request all the speakers to stick to the time limits.
Good morning, ladies and gentlemen. Thanks, Dr. Bastin, for having me in this session. So I am talking on one of my batchmates always used to tell, even we small pupil hooks on the Paranjonde, you know. So I thought decided we'll just stop talking about hooks and then start on with rexes, the rings. So no financial interest in this, but I'll be talking on a particular type. So look at this pupil. So this pupil looks very small, is it not? So if you look at this carefully on the top part, although it's not very clear, it's written 4.9, and this pink ring is 4.9 millimeters. So it is basically at least 5.5 millimeter pupil. So it is not, everything is not as small as we think, although it looks small. But then when it looks small like this, if you are not able to do a good rexes along this size of pupil, I would always put in a dilating device. So my now go-to thing is this Bhex ring. So there are specific forceps. This is a regular forceps which I am using. It can also be used, but ergonomically the others will be good. So I hold on to one of those loops there and then tilt a little with having a little visco underneath the iris also, and then tuck it in. Then go from the paracentesis. That will be good to have the chamber form very well. Hold on to the center. You can either hold on to the side circles also and engage one by one. But I feel now holding on to the center and tilting it sideways will be an easy way to get the whole thing in one shot. So two flanges are gone in. Now the last one is more difficult. So towards that I put little more sodium hyaluronate inside and then fill up and then use two instruments. One is the forceps through the side port and second is a Kugelensuk. So I push this one flange a little forwards and then pull the iris a little backwards. So here by doing it on both the sides, you can stretch half only. Otherwise, if you stretch the iris, you will have to stretch double. So now see, this is a pseudo exfoliation case. The pupil is dilated to 5.5 millimeters. So this is more than enough for us to do a 5.25 or even a 5.5 rexes. If you have done a rexes and if you are sure that the pupil is not going to come down, that is more than enough for you to do a clean phaco. So here you can notice that this is a very thin profile thing, and because this is a pseudo exfoliation case, it has maintained the pupil size all along the surgery. It doesn't come down. You don't have to worry about the iris at all. Otherwise, we have to keep worrying about not going close to the iris, no irrigation hitting the iris, pupil coming down. All those things can be just forgotten. And the thin profile does not get it into the way of your instruments at all. And one more good thing is that you can move the ring like a photo frame. If you want to see one particular point, just push it with your second instrument. And the IOL goes into the bag, and make sure that leading end goes straight into the bag. Don't land it in the anterior chamber. And before the haptic opens, the trailing haptic opens, it is better to get the haptic optic junction into the bag. Don't slide the IOL over the ring. That is one way you can avoid the dislodging the ring. Now I am just showing how to dislodge all the three flanges. You need not actually. I'll show you in further cases. It need not be completely dislodged. Only one is enough. And once it is in the anterior chamber, you can just hold it and withdraw. So this is supposed to be a disposable product. So now see the pupil. It has not been distorted much at all. You know, if it is a very small one, sphincter tears may happen, it will be there. But then see, it is relatively very, looks untouched. So that is one good thing about these rings. So look at the centration. So this is the virion coming on, and if you have placed it properly, see the centration. So you will get a very centered pupil, and your rexus is going to be very well centered, and this ring is a good marker. If you don't have these kind of markers, this is a very, you will get a very well centered rexus for the later implantation of, especially look in this case here, there is a toric IOL which is going in. So the toric IOL marks are clearly seen at the edges. One at least you will be able to see in this pupil size. That is enough, because in a small pupil, retracting it and seeing and then trying to adjust the IOL is very, very difficult. So after I wash all the visco and underneath the IOL also, and then position the IOL, then I put in again sodium hyaluronate into the anterior chamber alone for the release of these hooks, the ring, and taking it out. because I am not very comfortable doing it under saline, although it is possible. Under irrigation, it's possible, but I am not very comfortable. Sometimes iris, iris comes out through the incision and all those. And here, see, look at this pupil. If it is a 5.5, 6 millimeter pupil, we may think that IFIS may not happen. See, intraoperative floppiness when the patient is on tamsulosin. But at any stage, this can happen. See now what has happened? I just turned my tip towards the side, the irrigation went underneath or along the iris, and suddenly the billowing starts and the flutter happens and the pupil comes down and I accidentally catch the iris. So remember, any patient on tamsulosin and having a soggy looking iris like this and a mid dilated pupil, there is always a tendency for this pupil to come down. So your incisions have to be appropriate for the size of your instruments which you use, well fitting ones, not loose. See, when I irrigate, see the flutter of the iris, this is one indicator that the iris is going to be floppy and it is going to come down on you. So I went ahead and did a rhexis of 5 millimeters, 4.85 millimeters, but then still, this is at the beginning itself, when I am starting phaco itself, see the way the iris behaves, and it has started coming down. So to avoid this kind of a situation, putting in a ring or a hook at this situation is possible, but it is more risky holding the rhexis margin and all those while placing it. So if you find one like this, I'll straight away place a ring in the beginning itself. So this is a forceps, Bhex forceps, which is applied along with the ring. The ergonomics, the bend and all those, it's much better rather the regular forceps which we use. And here also it opens up down the jaws, not the sideways opening like the other one. The same thing which I showed before, but have all these air bubbles taken out. Because exactly where you want to do something, that air bubble will come and sit. So always take air bubbles out and then use this two-hand maneuver for the last one, subincisional. Retract the iris and pull the ring away so that you can engage it very well. So here again, not to drag the IOL along, not to hit the zone. So here I am taking it out through a paracentesis. So this even comes out through a paracentesis of 1 millimeter opening, that is also possible. So even then coming on to pseudoexfoliation ones with rigid pupils, if it is a rigid pupil, it is always better to give it a little stretch, because this is a very thin profile one, not very sturdy as the Malugian ring. So it is always better to have stretch on the sphincter so that we can easily engage the ring. So here is the UBIT case. It has a posterior synechia and this fibrin. You can see the fibrosis at the pupillary margin. And we release the posterior synechia and give it a stretch as we saw before. And here, this is in 2018, this was the early stages of development of this lens, and I was one of the evaluators of this, not lens, ring. This is the earlier version we were trying to use with the Sinsky and all, but now we have all changed to the forceps alone. And here if you notice, see the bending of the ring. This was because I had used it multiple times after autoclaving. So I don't suggest use autoclaving, but you can even ETO or use a plasma sterilizer and then it may retain for, see the bend which happens. So even with this bending, it can hold on to the iris, and if you then shift a little bit, as I will show you, this looks a little small now, but if you just push along the flanges, it will actually create a 5.5 millimeter opening with which you can continue. So I would suggest, I have now gone away from using iris hooks in routine cases, especially in sonlar dialysis or in a PC rent. If I need to have a very large opening, then I use iris hooks, or in a very intumescent lens, if I have a tendency for a runaway rhexis or an extension, I want to see the periphery of the bag, then I use hooks. Otherwise, I don't use hooks at all now. Thank you very much.
Thank you, Minu, for that wonderful